In the world of dentistry, cements are kind of the unsung heroes, right? They're the glues, the liners, the fillers that make so much of what dentists do even possible. Today, we're going to zoom in on one of the most classic, most recognizable materials you'll find in any dental office. We're telling the story of zinc oxide and eugenol cement.
Oh, you know exactly what I'm talking about. That really distinct kind of spicy, clove-like scent that just immediately makes you think of the dental chair. Well, guess what? That's not just some random air freshener. That smell is the signature of a key ingredient that's been used in dentistry for over 100 years, and it's right at the heart of the cement we're digging into today. So here's the game plan. First, we're going to get into the core science, which I like to call the chemical claw reaction. Then, we'll get properly introduced to zinc oxide/eugenol itself, take a peek at its secret recipe, and see how it all sets up. And finally, we'll give it a full performance report card and wrap up with a quick Q&A on the big clinical questions. Let's do it.
Okay, let's dive right in. To really get a handle on this cement, you have to start with its basic setting reaction, which involves something called an organometallic chelate compound. Now, I know, that sounds super complicated, but the idea behind it is actually surprisingly simple. See, the word chelate actually comes from the Greek word for claw, and that is the perfect way to think about it. Just picture a little metal particle. For us, that's a zinc ion. Now imagine an organic molecule that's shaped just right to reach out and grab that metal ion in this super stable claw-like grip. That's a chelate. And it's this claw formation that turns a simple powder and liquid into a solid cement.
And, you know, this whole chemical claw thing, it isn't just for our star player today. Zinc oxide/eugenol, or ZOE as we'll call it, is just one member of a whole family of dental cements that's set this way. You've also got stronger EBA cements and even some types of calcium hydroxide materials that are used to protect the tooth's nerve. They all work on this exact same fundamental principle.
So, with that background, let's properly introduce the star of our show. Zinc oxide/eugenol, ZOE for short, is really the classic example of a chelate cement. It's been a total workhorse in dentistry for decades, and for some very good reasons. When you see ZOE in the clinic, it usually comes in one of two flavors. You've got the old-school powder and liquid system, where you scoop and mix it yourself, but you'll also see this two-paste system. The chemistry is pretty much the same, but these pastes make it so much easier to get the perfect ratio every single time, which, let me tell you, is a huge plus in a busy dental office. So what's actually in this powder and liquid? I mean, the secret to any material's performance is always in its recipe. And with ZOE, every single ingredient is in there for a very specific and pretty important reason.
All right, let's break this recipe down. The powder, that's mostly zinc oxide, and that's our metal source. The liquid is mostly eugenol. Yep, the same stuff from cloves that gives us that famous smell. This acts as the organic claw, but there are other players too. The powder has a little bit of zinc acetate, and its job is to act as an accelerator to really kickstart the reaction. And the liquid often has some olive oil in it just to control the consistency, making the whole mix less sticky and way easier to work with.
Okay, so here's the thing about classic ZOE. Its biggest weakness has always been that it's just not very strong. So to fix that, manufacturers got clever and developed reinforced versions. By adding strengthening polymers, things like hydrogenated rosin or even polystyrene, right into the mix, they created a much tougher cement. This made it useful for some more demanding temporary jobs.
Okay, so we've got our ingredients. Now for the magic trick. How does it go from being this simple mix into a solid, hard structure? Well, it's not just drying out. It's a really specific and pretty cool chemical reaction.
And here is that chemical claw in action. As soon as you mix the powder and liquid, those eugenol molecules start hunting for zinc ions. And in this really elegant bit of chemistry, it takes exactly two eugenol molecules to grab onto a single zinc ion, forming that super stable chelate. This new structure is called zinc eugenolate, and as millions of these things link up, they form a solid mass. And just like that, our cement is set.
But wait, there is a secret to this whole reaction. There's one critical ingredient that doesn't come in the bottle or the jar, but is absolutely essential for the cement to set properly inside the mouth. And that ingredient is water.
And this is actually kind of genius. See, the reaction is incredibly slow in dry conditions, which is great. It gives the dentist plenty of time to work with it on the mixing pad. But the second that material is placed in the mouth, the tiny bit of moisture on the tooth, the humidity, plus the higher body temperature, they all act as a massive accelerator, causing it to set really fast. It's a clever piece of chemistry that's perfectly designed for the job.
So we know what it is, we know how it works,
But is it any good? Well, like any material, Zoe has a report card filled with some serious strengths and some major weaknesses. It's a classic story of trade-offs, and you've got to understand them to know where it fits in modern dentistry. Okay, on the plus side, its most famous quality is that it has a soothing or obtundant effect on the tooth's nerve, which is perfect for really deep cavities. It's also a great insulator against hot and cold, and it's bactericidal. It actually kills bacteria. But the cons are pretty significant. It has very low compressive strength, meaning it can't handle a lot of chewing force. It dissolves pretty easily in saliva, and, this is a big one, it messes with the setting of modern white fillings. So what does low strength really mean? We measure compressive strength in megapascals, or MPa. A basic ZOE clocks in at around 20 MPa. The beefed-up reinforced versions might get you to 40. Now, to put that in perspective, a permanent cement like zinc phosphate can easily hit 80 or even 100 MPa. That huge difference is the #1 reason ZOE is pretty much always just a temporary solution.
And what about it being highly soluble? Well, this quote from the source material explains it perfectly. Basically, any extra eugenol that didn't react can wash out over time. Then, water from your saliva gets in and attacks the cement structure, causing it to literally fall apart. This just makes it way too unstable for anything long-term inside the mouth.
So, let's put it all together. The good, the bad, the chemistry. Where does this classic material actually fit into a modern dental clinic? Let's connect the science to the real world and tackle some of the most important questions you might have.
And here it is. This is its main job today. Because it's soothing, it seals well enough for a few weeks, and it's weak enough that the dentist can remove it easily, ZOE is the perfect temporary cement. You'll see products like Temp Bond used all the time to hold a temporary crown in place while the permanent one is being made in the lab.
All right, time for a quick Q&A. First up, and this is probably the single most important rule for Zoe in the 21st century, why is it an absolute no-no to put it underneath a modern, tooth-colored composite filling?
The answer goes right back to that free eugenol. That same molecule that's so great at soothing the tooth's nerve is terrible for composite resins. It actually stops the polymerization reaction that makes the resin get hard. So if you put a white filling on top of ZOE, that eugenol will stop the bottom layer of the filling from setting properly, leaving you with a soft, weak bond that's pretty much guaranteed to fail.
Next question. We've kind of hinted at this, but let's just be totally clear. Can you use this stuff to permanently cement a final crown or a bridge?
And the answer is a hard no. And it's for the two big reasons we just covered. Its low strength means it would probably crack under normal chewing forces, and its high solubility means it would just wash out from under the crown over time, leading to leaks and failure. Its chemistry is built for the short term, not the long haul. And that really brings us to our last thought. I mean, Zoe is a material from a totally different era, right? It was around long before adhesive bonding and super strong ceramics. And yet, because of that unique combination of being soothing and being perfect for temporary work, it's still here. It makes you wonder, in a world that's always innovating, what does the fact that this simple, clove-scented cement is still around tell us about what really matters in taking care of patients? You know, in dentistry, you've got your classics, those go-to materials that have been around forever. But what happens when one of those classics, well, just isn't strong enough for certain jobs? That's where EBA cements come in. We're going to look at how this material took a dental workhorse and gave it a serious power boost. So just think about this for a second. We all know zinc oxide eugenol, right? ZOE. It's an absolute workhorse in the clinic. But what if you could take that same basic chemistry and just crank up the strength to a whole new level? That is precisely the question that led to the cements we're talking about today. All right, so here's our game plan. To really get what makes EBS cement so special, we'll first quickly touch on where they came from, their connection to Zoe. Then we'll dive into what's actually in the powder and liquid, figure out the cool chemistry that makes it all set, and see how that makes them so much stronger and more stable. And of course, we'll wrap it all up with a quick knowledge check at the end. So how do you improve on a classic? Well, you don't just throw everything out and start over. Instead, the smart folks who developed EB cements took a material that dentists use constantly and zeroed in on fixing its one big weak spot.
So here's the bottom line. EBA cement is basically a souped-up, reinforced version of ZOE. The whole idea behind its design was super simple. Keep all the good stuff about ZOE, but specifically engineer out its biggest problem, which was, of course, its lack of strength.
Okay, so to really get why it's so much stronger, we've got to look under the hood, right? And just like a lot of cements, it's a powder and a liquid system that you mix together. So let's break down what's in each of those parts. So this table right here, this is basically the recipe for eBay's strength. And the magic isn't in just one thing, but in how everything works together. The reactive parts that create the cement and the reinforcing parts that give it its muscle. First up, let's take a look at that powder.
Okay, so the powder is mostly zinc oxide. That's our main reactive ingredient. But, and this is the real secret sauce, almost 40% of it is just pure reinforcement. You've got quartz in there, which is super hard and stable. Think of it like the rebar you see in concrete. And there's a little bit of hydrogenated rosin just to help with the mixability. It's these fillers that are really the backbone of this cement's toughness.
All right, onto the liquid. This is where the EBA in the name actually comes from. It's got Ortho-ethoxybenzoic acid, we'll just call it EBA, and our old friend eugenol. And both of these are the active ingredients that are going to get that setting reaction started. Usually you're looking at a ratio of about 2 parts EBA to 1 part eugenol. So what actually happens when you mix that powder and liquid together? Well, the magic is all in a chemical process called chelation. Now, that might sound super complicated, but the idea behind it is actually pretty easy to grasp.
And here it is, the star of the show, the EBA molecule itself. If you look at it, you might notice its structure looks kind of familiar, a bit like eugenol. And that's not a coincidence. That similarity is the whole point. It's some really clever chemical engineering that lets both of these molecules do the exact same thing when it's time to set.
So what exactly is chelation? The best way to picture it is to think of a claw. You have a single molecule, that's our chelating agent, and it literally reaches out and grabs onto a metal ion, in our case zinc, from 2 or more different points. This creates this super stable ring-like structure, almost like it's locked in place, and that structure is called a chelate. And that is the setting reaction right there. When you mix everything up, both the EBA and the eugenol molecules act like those claws we just talked about. They latch onto the zinc ions from the powder, linking everything together into this solid, cross-linked matrix. And boom, that's your set cement.
Okay, so we've got our special ingredients in this cool chelation claw reaction. But what does all that chemistry actually mean in the clinic? Let's bridge that gap from the science to the real-world advantages you can actually see and feel. So the first big advantage comes down to the mix itself. Because that powder is so jam-packed with reinforcing fillers, you can get away with a much higher powder-to-liquid ratio compared to a regular ZOE. It's kind of like making concrete, right? The less water and the more sand and gravel you use, the stronger it's going to be.
And just how much stronger are we talking about here? Well, a typical compressive strength for EBA cement is right around 85 megapascals. To put that in perspective, that's way stronger than even the reinforced ZOE cements. If there's one number to remember about its performance, it's that one, 85 MPa.
This table really lays it all out, nice and clear. When you put it side by side with standard ZOE, you can see EBA isn't just a little bit stronger, it's in a totally different league. But check out that second line. It's also less soluble, and that is a huge deal. It means the cement is just going to last longer and not wash out in the mouth.
So why is that? Why is it less soluble? Well, it basically boils down to 2 things. First off, the chemical reaction is just more efficient, so you have less of that weaker, unreacted eugenol floating around. And second, that chelate structure we talked about, it's just naturally more resistant to hydrolysis, which is just a fancy way of saying it doesn't break down as easily when it gets wet. It's just a tougher bond that's built to last in the mouth.
All right, so we've established it's strong and it's stable, but where do you actually use this material in the clinic? Let's get into the practical applications.
So when you're working with it, it feels a lot like ZOE. Even moisture can make it set faster. Its primary job is as a luting cement, the permanent glue for crowns and bridges. But because it's so much stronger, it has another great use. You can use it as a base under fillings. It's tough enough to stand up to the pressure of condensing amalgam right on top of it. And hey, when it comes to patient comfort, its thermal properties are just as good as the ZOE materials we're all used to. Okay, we have covered a ton of ground, so let's do a quick knowledge check to make sure the key takeaways really stick. You ready? First question for you. Think back to that pie chart we saw. What are the 3 main things inside the EBS cement powder?
And the answer is zinc oxide, which is our main reactant, plus those 2 all-important reinforcing agents, quartz and hydrogenated rosin. Remember, it's that huge chunk of film material that gives it all that extra muscle.
All right, second question, and this is really the big one.
When it comes to strength, what's the main thing to remember about EBA cement compared to the old ZOE?
The key takeaway is that it's just in a completely different ballpark. With a compressive strength around 85 megapascals, it's significantly stronger than its ZOE ancestors, and that makes it perfect for those more demanding jobs in the mouth.
When you really think about it, ABA cement is just a perfect example of smart material evolution. It's about taking something everyone knows, pinpointing its biggest weakness, and then using some really clever chemistry to fix it. And that kind of leaves us with a pretty cool question to ponder, right? If this is what's possible just by reinforcing a classic, what does the next great leap forward for dental cements even look like?
Have you ever really thought about what happens when you get a filling? I mean, deep inside your tooth. Turns out there's this hidden hero at work, a material that basically acts as a bodyguard for the really sensitive core of your tooth. We're going to get to know that unsung hero, calcium hydroxide cement. Let's get into it. So just picture it for a second. Your dentist has cleaned out a cavity, and they're getting super close to the living, sensitive part of your tooth called the pulp. Before they pack in that final filling material, they need some kind of protective barrier. So what is that barrier, and how in the world does it actually work?
Well, here's the answer. You're looking at it right here. Dentists lay down this special protective layer, sometimes called a lining, or like in this diagram, a sublining, right over the deepest part of that cavity. You can really think of it as a tiny shield. And for a long, long time, the go-to material for this shield has been calcium hydroxide.
So here's our roadmap for this explainer. We're going to start with its super simple and kind of weak beginnings. Then we'll check out the clever toothpaste system that changed the game. We'll get into the fascinating chemistry of how it all hardens, touch on the modern light-activated versions, and then we'll wrap it all up with the key things you need to know.
All right, first up, let's travel back to the beginning. The earliest versions of this stuff were, well, incredibly simple, but that simplicity came with some pretty serious problems. You really can't get any more basic than this. The original idea was literally just to take some calcium hydroxide powder, mix it with water to make a paste, slap it into the cavity, and just wait for it to dry. Sounds easy, right? Well, in theory maybe, but in practice, not so much. For starters, this simple paste was a total mess to handle, and once it finally dried, it was extremely friable. That's a fancy word for saying it would just crumble and break apart at the slightest touch. Now, they tried adding things like methyl cellulose to make it stick together better, more like a real paste, but there was a much, much bigger problem hiding just beneath the surface. 8 megapascals. That was its compressive strength. Now let me tell you, that is basically nothing. It is nowhere near strong enough to handle the pressure a dentist has to use to pack a filling like an amalgam right on top of it. That protective layer would just shatter. So, yeah, a new solution was definitely needed.
And that solution was a much smarter, much stronger toothpaste system. This is what really became the gold standard for decades, and it's a great piece of chemical engineering. This is what you'll usually see in a dental office today. 2 separate tubes. You've got a base paste, and you've got a catalyst paste. When you mix equal lengths of these two together on a pad, a chemical reaction kicks off, and it creates this hard, durable lining that can actually stand up to the job. So what in the world is actually inside these 2 tubes? Well, this table breaks it all down. Now, I know it looks like a crazy list of chemicals, but don't worry. The real story here is what each ingredient does. Let's regroup these by their function.
Okay, here's the clever part. The main reactive ingredients are kept separate on purpose. In paste 1, you've got the calcium hydroxide and zinc oxide, mixed into a carrier, that sulfonamide, which just makes it a paste. Paste 2 holds the other key player, glycol salicylate, along with some fillers. The real magic, of course, happens when you mix them together.
All right, so we've got the ingredients, but how do they go from being 2 soft pastes to a hard, protective cement? The answer is just a really, really cool bit of chemistry.
The main reaction is called chelation, and honestly, the best way to think about it is like a tiny chemical claw. There's a specific molecule, the chelating agent, that's designed to hunt down and grab onto metal ions, locking them into place and forming a super stable structure.
And here it is. This is our chemical claw, butylene glycol disalicylate. Take a look at its shape. You see those 2 sections that look kind of like rings with the OH group sticking off? Those are the jaws of the claw, and they are perfectly shaped to snap shut around a metal ion and form a crazy strong bond. So here's how it all goes down. The second those 2 pastes get mixed, our chemical claw, the chelating agent from paste 2, goes on the hunt. And here's the big twist. It pretty much ignores the calcium. Its main target is the zinc ions from paste 1. It starts grabbing them, linking them all together into this huge tangled network, and that is what makes the cement set hard. And this right here is the key takeaway. It's kind of funny, right? Even though we call it a calcium hydroxide cement, the calcium itself doesn't really do much in the setting reaction. It's the zinc ions that are the stars of the show, doing all the heavy lifting in that chelation reaction to give the cement its strength. The calcium is there for other reasons, mainly for its therapeutic alkaline properties next to the tooth pulp.
Now you know technology never sits still, so today you might hear about light-activated calcium hydroxide cements, and you'd probably think it's just a simple upgrade, but chemically, they're a completely different animal.
Yeah, even though the names are similar, these newer materials don't use that cool chelation reaction at all. They've actually borrowed their technology from a totally different part of dentistry, the world of resin-based or composite fillings.
This slide nails the difference perfectly. Over on one side, you've got our two-paste system. It hardens because of chelation, our chemical claw grabbing zinc ions. But on the other side, the light-activated stuff uses a process called polymerization. It's full of tiny molecules that when you hit them with that blue light from the dentist gun, link up into these long, super strong chains. It's two completely different chemical roads leading to the same destination.
Okay, time for a quick fire round. Let's recap the most important points from all this to make sure everything is crystal clear.
So first up, why do we even need to bother with these more complex cements? What was so bad about that original, super simple mix of powder and water?
The answer, plain and simple, is that it's just way too weak. At only 8 megapascals of compressive strength, it would just crumble under the pressure needed to place a filling. It would be totally useless as a protective base. And question number 2. What's that core chemical process, that secret sauce, that gives the modern toothpaste system all of its strength and lets it set into a hard, reliable cement?
The answer, in one word, chelation. It's that chemical claw, the glycol salicylic, snapping onto zinc ions to build that strong cross-link structure. And it's so important to remember this is a totally different universe from the light-activated versions, which use polymerization. It's a pretty amazing reminder that in dentistry, names can be deceiving. You can have two materials made for the exact same job that are, chemically, worlds apart.
We're going to talk about one of the real unsung heroes of the dental world. It's not the flashy drill or the final filling, but it's this special cement that can actually help your tooth heal itself. So yeah, let's do a deep dive into this amazing material, calcium hydroxide cement. So picture this. You've got a really deep cavity. The dentist has cleared out all the decay, but now the bottom of that cavity is super close to the pulp. You know, the living, breathing nerve center of your tooth. We're talking about a situation where one wrong move could mean a root canal. That tooth is in some serious trouble. So what's the one thing that stands between saving that delicate pulp and having to do a way more invasive procedure? What can a dentist put in that tiny, fragile space to protect the nerve and give the tooth a real fighting chance? That's the big question we're going to answer today. And you know what? The answer comes in the form of this deceptively simple paste. So let's meet our hero, calcium hydroxide cement. This is the stuff that's designed specifically to be a protective layer in the deepest, most vulnerable parts of a cavity. And this is what it looks like in the real world. Pretty basic, right? It starts out as two separate pastes that you squeeze out of these tubes. The dentist just mixes equal amounts together on a little pad, and in that moment of mixing, boom, something really powerful gets created, ready to go to work and save that tooth. So what's actually in these pastes? What's the magic formula? Well, if you take a look at the chart, the first paste has our main ingredient, calcium hydroxide. Think of this as the active healer. Then, the second paste has something called glycol salicylate, and that's the catalyst, the thing that really gets the reaction going and helps the paste set up and harden. All the other ingredients, they're kind of like the supporting cast. They help with the consistency and make sure the cement actually shows up on an X-ray. And just to geek out for a second, this is what one of those key reactive ingredients, the salicylate, looks like on a molecular level. You don't have to be a chemist to appreciate this. It's its complex little structure that lets it react perfectly with the calcium hydroxide to form that solid, protective shield inside your tooth. Pretty cool! Okay, so we know what it's made of, but how does it actually behave inside the tooth? To really get that, we need to look at its unique properties, and that includes its surprising strengths and, well, what might look like weaknesses at first glance. First thing you need to know, it has a very low viscosity. Basically, that means it's pretty runny. You should be thinking less like a thick toothpaste and more like, say, ketchup. And this is actually a good thing. It lets the dentist flow a really thin, precise layer exactly where it's needed, right at the bottom of a deep cavity, without having to push down hard. Now, how it hardens is also really interesting. The classic toothpaste system has a secret activator, moisture. Yep, even in a cavity that's been dried, there's enough natural moisture from the tooth to make this stuff set in just a few seconds. The more modern, resin-based versions give the dentist a bit more control. They only set when you shine a special blue light on them. So let's talk about strength. Its compressive strength, that's its ability to resist pressure, is about 20 megapascals, or MPa. Now, I gotta be honest, in the world of dental materials, that number is not gonna win any awards for strength. You're probably looking at that and thinking, is that really strong enough? And here's the key thing to remember. It doesn't need to be the strongest. Its job isn't to be the final filling, its job is to be a protective liner. And at 20 megapascals, it's absolutely tough enough to handle the pressure of a dentist packing the main filling material, like amalgam, right on top of it. It is perfectly engineered for its very specific job. All right, so we've covered the what and the why. Now let's get into the how. Let's see exactly how a dentist puts this material to use in a real procedure. It's often used in a technique called sublining. So first, the dentist very carefully places a thin layer of our calcium hydroxide cement right over the deepest part of the cavity, the part that's closest to the pulp. Next up, a stronger cement base is placed over that for more structural support. And to finish it all off, the permanent filling goes right on top to complete the whole restoration. And this diagram? It lays it all out beautifully. You can see all the layers perfectly. Right there at the bottom, protecting that super important pulp tissue, is our sublining of calcium hydroxide. Above it, you've got the stronger support layer, and then the final amalgam filling sits right on top, bringing the tooth back to its original shape and function. Up until now, we've basically talked about this cement as just a passive barrier, a shield. But now we get to its most incredible feature. This is its biological secret weapon. This material doesn't just sit there, it actively works with your tooth. Hey, remember how I said some of its properties might seem like weaknesses? Well, get this. The cement is actually highly soluble in water. Now, you'd think that's a terrible thing for something that lives in a wet mouth, right? But in this case, that weakness is actually its greatest strength. Because it's soluble, it allows the calcium hydroxide to slowly leach out into the tooth. And this does two incredible things. First, it creates a highly alkaline environment, a pH that's way too high for any leftover bacteria from the decay to survive. It's absent. And second, and this is the really amazing part, it gently irritates the pulp, which stimulates it to build a brand new layer of protective dent. I mean, just let that sink in for a moment. The source material says it's, and I'm quoting here, able to initiate calcification and formation of a secondary dentine layer. The cement is literally telling the tooth to build its own natural armor, to heal itself from the inside out. That is just an incredible example of bioactive materials at work. So what's the big picture here? This classic material has evolved over the years, and it teaches us a really powerful lesson about working with our body's own healing powers, not just against problems. Let's wrap this up with the most important takeaways. So, modern dentistry has come up with these resin-based versions that are much less soluble, which makes them last longer. But, and this is a big but, it's kind of a double-edged sword. If less of that healing calcium hydroxide can leach out, you might actually lose some of the very antibacterial and healing powers that make the original stuff so special. It's a classic trade-off. Okay, quick knowledge check for you, just to make sure the most important point really landed. Why is a property that sounds pretty bad, high solubility, actually a fantastic thing for this cement? And the answer is, its solubility is the engine that drives its healing power. It's what allows the key ingredient, the calcium hydroxide, to be released from the cement so it can get to work killing bacteria and, most importantly, signaling the tooth to repair itself by forming new dentin. And that really just leaves us with one final big thought. This humble dental paste is so much more than a simple cavity liner. It's a bioactive material that actually teaches a tooth to heal itself. And that just makes you wonder, what's next? What other materials are we going to develop that don't just patch our bodies up, but actively work with them to regenerate and heal? calcium hydroxide cement. This stuff is way more than just a simple paste. It's a bioactive powerhouse that has an incredible story of saving teeth, literally one molecule at a time. Yeah, I bet you recognize this little box, right? It's a staple in pretty much every dental clinic. But don't let that simple packaging fool you. The science squeezed into these two little tubes is a total game changer. So what is the secret behind this paste? I mean, what actually happens when you mix these two together? You ready to become an expert? Here's our roadmap. We're going to start with the basics, what's the recipe? Then we'll jump right into the controversy, the great liner debate. From there, we'll get into the clinical do's and don'ts, check out its all-star role in root canals, and then we get to see some real dental magic in action, saving young teeth. So stick around for the big takeaways at the end. Okay, first things first, let's get properly introduced to our main character today. Before we can really appreciate what it does, we need to understand what this stuff actually is. So let's break down the recipe for this amazing reparative material. It really all begins with that simple question, right? What are the ingredients that give this cement all its special powers? Well, the answer is in this really clever two-paste system that's designed to give a perfect, predictable mix every single time. So let's take a look inside those two tubes. In paste 1, you've got the main players. Calcium hydroxide, that's the bioactive star of the show, and some zinc oxide. Then you've got zinc stearate, which is the accelerator. It's what kicks the whole reaction into gear, and it's all held in an oily carrier. Now, over in paste 2, we have glycol salicylate, the other key reactive ingredient, plus some important extras, like radiopacifiers. That's just a fancy word so it shows up on an X-ray. The real magic, of course, happens when you mix them together. That's what triggers the chemical reaction that makes the cement. And just so you can put a face to the name, here it is. This is the molecular structure of a salicylic compound, just like the one in paste 2. I know, might look a little complicated, like something from a chemistry exam, but that specific structure is what allows it to react with the calcium hydroxide and make everything harden up. It's also responsible for that very distinctive, almost medicinal smell you might recognize. Okay, so now we know what it is, let's get into the drama. Because for years, there's been this huge clinical debate raging on about whether you even need to put a calcium hydroxide liner under modern tooth-colored composite fillings. It's a real clash of dental philosophies. Seriously, this debate is huge. On one side, you have Team Adhesive. These are the folks who believe modern bonding agents are so incredibly good at sealing the tooth that an old-school liner just isn't necessary anymore. In fact, they argue it actually gets in the way and weakens the final filling by taking up precious real estate that could be used for bonding. But then, on the other side, you have Team Liner. They're saying not so fast. They point to these super sensitive lab studies showing that the tiny, fluid-filled channels in our dentin can still leak even with the best adhesives. For them, that little liner is a crucial insurance policy against bacteria getting in. So, with two really strong arguments, where do we land today? How does a dentist actually make this decision for their patients? Well, let's look at the evidence-based consensus that cuts through all the noise and guides modern dental practice. Thankfully, the consensus is pretty logical, and it's all based on risk. Rule number 1, if the pulp, the living nerve of the tooth, is actually exposed, you absolutely have to cap it. That's a non-negotiable. Rule number 2, for those shallow cavities way far away from the pulp, no liner is needed. Your adhesive is plenty. And then there's rule number 3, and this is the crucial judgment call. For those really deep cavities, the ones that get uncomfortably close to the pulp, it's considered wise to place a little protective liner just over that deepest spot. And this diagram illustrates that third rule perfectly. See that? The calcium hydroxide isn't a thick layer smeared all over the place. It's placed very strategically as a sublining, just a small, targeted little shield right over the area closest to the pulp. The rest of the cavity floor is left open for the bonding agent to do its thing. It really is the best of both worlds. You get that targeted pulp protection, and you get maximum bond strength. But the story doesn't end with fillings, not even close. Calcium hydroxide cements are absolute superstars in the world of endodontics, root canal therapy. Their unique properties make them pretty much indispensable when you're treating the very core of the tooth. So why is it so perfect for this job? Well, it comes down to 3 key things. First, its high pH makes it incredibly antibacterial, which is exactly what you want when you're trying to disinfect a complex root canal system. Second, even with that power, it's amazingly biocompatible, meaning it's not irritating to the very sensitive tissues at the tip of the root. And third, the chemistry is tweaked just for this purpose. The formulations for root canals have retarders mixed in, which slows down the setting time, giving the dentist plenty of time to work in that warm human environment inside a tooth. And that brings us to one of the most incredible uses for this material, a procedure that honestly feels a little bit like magic. It's called apexification. This is where we see its true power to be bioactive and to save teeth that not too long ago would have been lost for good. So, what in the world is apexification? Well, to put it simply, it's a treatment that actually encourages the body to build a hard tissue barrier at the tip of an immature root. You can think of it as gently nudging the tooth to finish building itself, even after the living pulp inside is gone. Let's walk through this step by step. So imagine a young patient has a tooth that's still growing, but the pulp gets infected. The problem is the root tip is still wide open, kind of like a funnel, which makes a normal root canal impossible. That's step 1. So for step 2, the dentist cleans out the canal and packs it with a special non-setting calcium hydroxide paste. Now here's the amazing part. The presence of that material stimulates the cells of the root tip to start building a hard, calcified barrier, basically closing off the end of the root. Once that barrier shows up on an X-ray, the final step is to remove the temporary paste and place a permanent root filling. It is an absolutely brilliant way to save a young person's tooth. Whew, we have covered a lot of ground here, right? We've gone from basic chemistry all the way to advanced biology. So let's pull it all together and really lock in the most important things you need to remember about this incredibly versatile cement. Okay, so if you remember anything, remember this. It has 5 starring roles: as a direct caparate on an exposed pulp, as a subliner in really deep fillings, as a key ingredient in root canal sealers, as a temporary antibacterial dressing inside the canal during treatment, and, of course, its most magical role, inducing apification in young teeth. But, and this is a big but, every hero has its kryptonite. It's so important to know what this stuff can't do. Its 2 biggest weaknesses are that it's pretty soluble, meaning it can wash out over time, and it has low mechanical strength. This means you would never, ever use it as a permanent cement for something like a crown or a bridge. It's just not strong enough for that kind of heavy lifting. All right, let's do a little rapid-fire Q&A to make sure all these concepts are locked in. First question, why exactly is using a liner under modern fillings so controversial? The whole debate really boils down to this. Modern adhesives are amazing at sealing the edges of a filling, which makes some dentists feel a liner is redundant. But at the same time, very sensitive lab studies suggest that getting a perfect seal on every single microscopic tubule is nearly impossible, which is why other dentists feel a liner is still a really smart safety net. Okay, next one. Let's simplify it. What is the main goal of that whole apexification procedure? The main purpose is to get the body to build a hard tissue barrier, a wall, at the end of an undeveloped root. This creates a solid stop, or an apex, which then makes it possible for the dentist to go in and properly clean, shape, and seal that root canal with a permanent filling. And let's finish on this thought. Calcium hydroxide was really one of the first truly bioactive materials we had, a material designed not just to sit there and do nothing, but to actively cause a positive biological response. So, given everything we've seen it can do, how might our understanding and use of even more advanced bioactive materials change how we treat teeth and stimulate repair in the future? It's a really exciting frontier in dentistry.